medical director of the Providence ALS Center. Many of you know her very well. Some of you are meeting her for the first time today. But the key thing is that most of you who are her patients also know her, that she's a compassionate and caring person. But I know her as both a board member of the ALS Association since 2001, but also a very distinguished medical doctor. She graduated with her medical degree from the University of Virginia Medical School, as well as having a Ph.D. in neurobiology from Albany Medical College in New York. She completed her postdoctoral fellowship at Harvard Medical School and had teaching stints at Brigham and Women's Hospital, Mass General, and OHSU. And so, and really, since we're really excited that in 2015 we are celebrating our 10-year anniversary of the establishment of the Providence ALS Center. So welcome, Kimberly Goslin.
Is this turned on? Does everyone hear me? No? So I guess I have to speak up louder. Does everyone hear me now? Yes. Okay, great. So it's nice to be here, and it's very nice to see so many friendly faces as a speaker. I'm going to be giving a general overview of some of the things that are happening in ALS at this point. It's been an exciting year in ALS, partly because of the Ice Bucket Challenge, but also because of all the research that's being done, looking at new understanding of ALS and potential treatments. So I'm going to start with, I know many of you are people with ALS and people who are familiar with it, but I'm going to start with some basic information about ALS. Then I'm going to talk about some recent research findings in genetics and pathogenesis, and then ongoing and future clinical research. And I may touch a little bit on the challenges of drug development, which Steve Gibson already talked a little bit about. And then I'm going to give you a sampling of some of the exciting clinical trials that are coming up. So I think we all know that ALS is a motor neuron disease. It is the most common type of motor neuron disease. This picture shows on the left a healthy motor neuron, and you see that there's a cell body and dendrites, and then a long axon that connects to the muscle and makes the muscle work. In ALS, the motor neurons actually die, and as a result of that, muscles waste away. And so this leads to paralysis of all voluntary muscles, arm muscles, leg muscles, speech and swallowing muscles, and breathing muscles. Oddly enough, it doesn't affect eye muscles. And so in very advanced stages of diseases, eye movements can be used to communicate. Ultimately, most patients die of respiratory failure. ALS is unique among motor neuron diseases in that it affects what are called upper and lower motor neurons. And people always ask about this, and this doesn't refer to arms versus legs. It refers to the connectivity of the nervous system. So you have a motor neuron that comes from the cortex, from the brain, and travels down the brainstem and the spinal cord, and that's your upper motor neuron. That connects to the lower motor neuron that goes out directly to the muscles. And when each type of motor neuron is affected, you get different findings or different complaints. When the upper motor neurons are affected, you get stiffness or spasticity, and you get hyperactive reflexes and abnormal reflexes like Babinski response. When the lower motor neurons are affected, you get wasting of muscles, you get twitching of muscles, which is called fasciculations, and you get weakness. And the EMG that I think most patients with ALS have had is looking for abnormalities in the lower motor neurons. And this unique combination is really only found in ALS. There are not many other things that can look like that. So when someone has classic ALS, it should be fairly straightforward to diagnose, but I'll show you later that it's not. So some basic demographics. The incidence of ALS is 2 to 3 per 100,000. The mean age of onset is 58 to 63, and it's younger for familial, 40 to 60. The peak incidence, though, is actually 70 to 79, and I have patients ranging in age from 21 to 92. Average life expectancy is 3 to 5 years, and about 5 to 10% is familial. Though I'll talk about that later in terms of how there's a blurring of the lines between familial and sporadic a little bit. It's a little bit more common in men than women. Steve talked about risk factors for ALS and the fact that we really don't have a great idea of the risk factors and how important the ALS registry is to try to get better ideas. And in fact, those of you who come to my clinic, on your clinic letter, the very bottom is the website for the ALS registry. So maybe you haven't read your letters. I don't know. It's always there. These are really just possible risk factors. And I've starred the ones that have the strongest evidence. So as you get older, it gets more likely that you will have ALS. Male sex is a risk factor. Smoking does seem to be a risk factor. Military service, it's estimated that people in the military have a 2-fold incidence of getting ALS, and it's not understood why. There are a lot of theories. And I do mention professional soccer. There are a number of articles about that. It's thought maybe at this point that if that is a valid risk factor, it may be more related to the head trauma, the headers that soccer players do. There are chemicals seem to increase the risk factor: lead, formaldehyde, and pesticides. And most recently, the thing that's been in the news a lot is concussions and the risk of repeated concussions as a risk for basically all neurodegenerative diseases, including Parkinson's, Alzheimer's, and ALS. Things that seem to lower the risk of getting ALS: people, high BMI, so people who are a little bit overweight seem to have a lower risk of getting it, and high vitamin E intake seems to decrease the risk as well. Interestingly enough, though, once you have ALS, a high vitamin E intake doesn't seem to have an effect on progression. High intakes of carotenoids seem to help, and recent studies, this one study in particular, shows that overall high level of physical activity seems to decrease the risk of ALS. And in this one study, it decreased the risk by about 35%. And the more active the person was, the lower the risk. But there's a long way to go in terms of understanding what the risk factors for all ALS are. So it is a motor neuron disease, and as such, we think about most of the symptoms being related to weakness and muscle function. But there are a lot of other symptoms that go with ALS. And so this slide shows the incidence of other symptoms, starting at the top with the most common and going down to the least common. Clearly, muscle cramps, fasciculations, and stiffness are the most common, and those relate to motor neuron dysfunction. But depression is common. Fatigue is a huge complaint. Constipation, difficulty sleeping. And the difficulty sleeping is multifactorial. It relates to pain and mobility and anxiety and breathing. Sialorrhea, which is excessive saliva, anxiety, dry mouth, thick phlegm, labile affect. And labile affect refers to something called pseudobulbar affect, which is the tendency for the emotions to be close to the surface and more difficult to control. So people find that they laugh or cry when they're not necessarily feeling that good or bad. And there is a good medication for that called Nudexta. Urinary urgency is common, and laryngospasms can occur. What's not shown in this slide is 2 other things that are quite common. And one is the fact that ALS patients, actually there's a fairly high frequency of cognitive impairments in ALS. And about 15% of people with ALS have severe cognitive impairment that's called frontotemporal dementia. And then they say that about 30% have some mild cognitive impairments. The other thing that's not listed is pain. And when we're first diagnosing ALS, almost part of the diagnostic criteria are painless weakness. But as the disease progresses, pain becomes more common for a lot of reasons: spasticity, immobility, joint contractures, a variety of things. And so it does become common as the disease progresses. I don't know how you talked without drinking water. You made it through all the way through. So I've said that with classic ALS, it really should be pretty clear-cut. Upper and lower motor neuron findings, there's not a lot else that does that. But I think one of the things most patients have experienced is the long diagnostic delay. This slide looks at the time to diagnosis for different types of patients, whether it's bulbar patient or limb onset, old or young. And on average, the time to diagnosis is about 12 months. And on average, each patient sees about 3 doctors to lead to the diagnosis. And so unfortunately, many patients are not the classic patients. Some patients have more upper motor neuron findings and not many lower motor neuron, or the reverse. And so it can take a lot of diagnostic testing to lead to the diagnosis. And this is one of the reasons that what Steve was talking about was having a biomarker. We need a biomarker that's going to enable us to diagnose ALS better, and also to use in clinical trials as a marker of progression. I want to mention the ALS Functional Rating Scale now, because I'm going to mention it when I talk about clinical trials. And the ALS Functional Rating Scale, we use the revised one, is a tool to look at ALS progression. And it's a measurement that we make at every single clinic visits that our patients come to. And the tool has grades patient on a scale of 0 to 4 for 12 different domains. And those are listed here: speech, salivation, swallowing, handwriting, cutting food, dressing, turning in bed, walking, climbing stairs, shortness of breath. And so a normal score in someone who doesn't have many symptoms would be 48. And then as the disease progresses, that drops. The average rate of progression for ALS is to drop about 1 point per month, though there's a wide variation. And so I will be mentioning the ALS Functional Rating Scale. In terms of genetics of ALS, it's estimated that about 5 to 10% of ALS is familial, but that incidence is likely underestimated. And it's underestimated because of a couple things. One is the small size of families leads to an underestimate, and the other is that some genes, while they cause ALS, have an incomplete penetrance, meaning that they don't always cause ALS, or by the time someone dies, it may not cause ALS, and that's called the penetrance. And that leads to an underestimate of how frequent familial ALS is. There are now 35 known genes that explain, or at least, I didn't check this week, and they seem to come out pretty fast. The 35 known genes explain 75% of the cases of familial ALS. One of the things I find really interesting and something that's evolving is that clearly there are genes that cause ALS, but there are also genes that seem to decrease the risk or just increase the risk or slow the progression or speed the progression if you have it. So your genetic makeup is very complex in terms of how it leads to ALS or progression with ALS. This is just a slide that shows the exponential rise in the discovery of new genes. The first gene for ALS was discovered in 1993, and it's the gene for superoxide dismutase. And Dr. Beckman's going to be talking more about that. It's one of the more important genes because we have a lot of animal models of ALS based on that gene, so it's led to a lot of important research. but clearly the gene discovery is continuing to increase. And one of the important things about that is each new gene that is discovered leads to additional understanding about ALS and pathogenesis and how we will potentially treat it. This is just a partial list of genes that cause ALS, and I've highlighted a few. The gene for the first one, SOD1, is, as I said, very important, and Dr. Beckman will talk about that. C9orf72 is one of the more recent ones. It was discovered in the last few years, and it's actually the most common cause of familial ALS. It explains about 40% of familial cases, and what's interesting is it also explains 10% of cases that were thought to be sporadic. The other interesting thing about that gene is that it's associated with frontotemporal dementia. So some patients that have the gene may present with frontotemporal dementia or with ALS and frontotemporal dementia. TDP43 is another important gene. TDP43 is a protein that is found in many of the protein aggregations in motor neurons. And so discovering a gene for TDP3 as a cause of ALS is going to lead to a lot better understanding of ALS. All of these 35 genes, when you look at them, they can be broken down into a number of themes of what they do and how they may cause ALS. And so these are the four most important themes of ALS-causing genes. And the first one is a disturbance of protein stability. It appears that what many of the gene defects do is they result in proteins that are shaped abnormally and that tend to aggregate. And there's a theory that that aggregation of abnormal proteins leads to neuronal toxicity. There's also often a disturbance in RNA regulation, which leads to many areas of neuronal dysfunction. And then disturbance of cytoskeletal function is also important. And the cytoskeleton is the backbone of the motor neuron, and it's important for transport of proteins and organelles all over the neuron. And so when the cytoskeleton isn't working, the neuronal function deteriorates. And then some genes lead to susceptibility to environmental toxins. So one of the things I just want to emphasize is that the concept of sporadic versus familial is changing. It's an older concept, and there's sort of some blurring of the lines. The newer concept is that there has to be a burden of disease-causing factors to lead to ALS. And that may be your genetic load, the genes that you have that make you more likely to get ALS or less likely, cell damage that occurs with age, or environmental factors. I've mentioned that there are genes that make you less likely to get ALS or that make you progress, seem to make you progress more slowly if you have it, or more rapidly. And Ephrin B2 is one of these. Ephrin B2 is a protein that actually prevents motor neurons from repairing. And that protein is increased in patients with ALS. And what they've shown is that in patients with familial ALS, when they've looked at different genes for Ephrin B2, the genes that resulted in higher levels of Ephrin B2 correlated with more rapid progression. And the Ephrin B2 gene that resulted in lower levels correlated with slower progression. So this is important, and as are so many of these other genes that are being discovered, because already Ephrin B2 blockers have been developed, and they're moving toward clinical trial. No, it wouldn't be a biomarker. So in terms of ALS pathology, this is a picture of the cell body of a motor neuron. And what the arrow is pointing to is aggregated proteins in the cytoplasm of the neuron. These used to be, before we knew much about ALS, they used to be called Bunina bodies. And most of these contain the protein called TDP43, which is one of the reasons that gene discovery is so important. This slide is deliberately busy, and it's because I want to emphasize how many complex pathways affect motor neuron death. So there are lots of things that seem to be going wrong in the motor neurons that may make the motor neurons die faster. And so I've just shown you, so this is a motor neuron cell body, its axon, and the muscle fiber that it goes to. And some of the things that I've listed here are things like protein aggregation, which I've already mentioned, mitochondrial dysfunction, RNA processing abnormalities, impairment in axonal transport, and microglial activation and leukocyte filtration, which are markers of inflammation. And neuroinflammation, I'll come back to, because one of the clinical trials is with a medication to prevent neuroinflammation. Each of these separate processes are now targets for medication development. And so I will be mentioning them when I talk about some of the clinical trials that are going on. So I'm going to talk more about some clinical research that's going on now. And I want to talk a little bit about the challenges of clinical trials in ALS. Steve already talked about expanded access, so I'll just touch on it and then go into some of the clinical trials that are coming up now and that look promising. So ALS, I think Steve talked about how long it can take to develop a treatment for ALS or for any disease. 10, 15 years from the time that you identify a target. And that's one of the reasons that so many of the clinical trials that you see are using medications that are already available for one reason or the other. But once you have a medication, ALS is difficult to study. One is because of disease heterogeneity. As you can all know, people progress extremely differently. Average life expectancy is 3 to 5 years, but it really ranges from 6 months to 15 years. And it affects different areas of the body differently for each patient. The table or the graph shows rate of progression in a population of ALS patients using the ALS FRS. Average rate of progression is about 1 point per month, but there's a wide range of how patients progress, and that makes it difficult to do clinical trials. The other thing about ALS is that, in general, patients are diagnosed fairly late. And you saw how long it can take to come to diagnosis, but it's also estimated that by the time someone has weakness, they've already lost about 50% of their motor neurons. So we never really get to see ALS in the earliest stages of disease. There's a lack of biomarkers, which makes it hard to diagnose and also hard to do clinical trials. As Steve talked about, it's a rare disease, so it's often hard to get the numbers of patients for clinical trials. And then, as he mentioned, it takes a long time to bring new drugs to market. So he talked about expanded access, and I bring this up, I wanted to just mention it in regard to this medication GM604, which a lot of people have heard about and asked about. There was a lot of hyperbolic statements about GM604 that led to a push to get it approved for expanded access. And I just wanted to point out some of the difficulties of expanded access. So this is a way of getting access to medications that are not yet approved by the FDA. But it's an extremely, at this point, cumbersome process. I've been involved in it with a number of medications, and basically the patient has to ask their physician to fill out paperwork that, I don't know if this is true, but I saw in the literature that it's been estimated that paperwork takes 100 hours to complete. The patients must meet stringent criteria. Benefit must outweigh risk, and in some of these medications where they haven't had a lot of clinical trials, it's hard to assess that. The FDA has 30 days to respond once the paperwork has been submitted. The physician also has to submit to their internal review board to get their institution to approve the medication. The other problem is that even if the FDA approves expanded access, it doesn't compel the company to make the drug available. And many companies can't meet the demand or don't want to take the risk. And a couple medications that I tried to get available for my patients, the companies just wouldn't agree to compassionate use or expanded access. And the medications are not covered, and so expanded access also favors people who are more wealthy. This topic of expanded access has come up in every ALS meeting that I've gone to recently, and there's a lot of debate about it because researchers feel that expanded access may undermine ongoing clinical research. And my understanding is that the FDA has proposed an application to streamline this process, though it's not been approved. And I think Steve already mentioned that at least 5 states have enacted a right to try legislation, which is a way of trying to bypass federal regulation. So I wanted to mention GM604, and it turns out Steve Gibson knows quite a bit more about this than I do because there's not much to find out about it. But a lot of patients have asked about this, and this was based on very hyperbolic statements by the company that I think haven't been supported. And in Genervum's website and their press releases, what they claim is that GM604 is an embryonic motor neuron trophic factor that is the master regulator of the human nervous system. And that's clearly an overstatement. They say it modulates a large number of ALS-related genes, and it was able to dramatically slow the progression of disease. What we don't actually know a lot about GM604, I did a literature search on it. It's also called RTP1. There are not many articles that have been printed about it. Some of the articles I found suggest that it's involved in olfactory receptors. And this, I say Genervum hasn't followed an IND. They haven't followed a NDA. All these, can't get them quite right, NDA. And they had a small clinical trial, but they haven't made that data available. And it was a 2A trial with 8 patients receiving the medication over a 12-week period. And they talked about modulation of biomarkers. And one of the things I've said is there's not real clear biomarkers at this point for ALS, though a number of biomarkers are being looked at. And one of the other things about GM604 is that the company is just not being transparent. Both the ALSA and the FDA have repeatedly asked for information and to move ahead with further trials, but they haven't gotten a response. So the thing I would caution, and I think everyone knows this, is you can't believe everything you read on the internet, and there are going to be people who take advantage of the urgent situation that most ALS patients face. And I also want to just point out that I think most of us are in favor of expanded access, but it does have some controversy in terms of knowing when a medication really should be made available for expanded access. This is a list of clinical trials, some of the clinical trials that are going on. I'm going to talk about the trials on the left. On the right are some other really interesting clinical trials, and I think one of the more important topics is this treatment option called copper ATSM, which Dr. Beckman, I think, is going to talk about. So I'm not touching on it. But I will start with stem cells. And stem cells, obviously most people are interested in, and this is a potential cure of ALS, and we're not at that point. But some of the results that are coming back on stem cell trials are very promising. And there are 2 types of stem cell trials that are being done in the United States. One is called the Brainstorm stem cell trial, and that we really don't have much information about that, so there's no data I can present. It's called they use what are called neuron stem cells, which are bone marrow stem cells that are taken from the patient's own bone marrow. They're made to expand to make more of the stem cells, and then they're reprogrammed to make astrocyte-like cells that secrete a growth factor. And astrocytes are not motor neurons. They're the cells that support motor neurons and help keep them healthy. And these stem cells are then injected into the spinal fluid or the muscle. So at this point, there's no United States data available. There was a phase 1 and a phase 2A trial in Israel, but no data has been published on that. Their press release said that the stem cell trial, they saw a significantly slower decline in overall clinical and respiratory function in 6 patients that received a spinal fluid injection of cells. So small number of patients, and we really don't know what that means at this point. The more exciting stem cell research that's being done is called NeuralStem ALS trial. And this is something that we actually have some very exciting data for. So for this type of clinical trial, they take the stem cells from human fetal spinal cord. They then have those cells differentiate into neuronal cells that have some characteristics of neurons and some characteristics of astrocytes. So they're not clearly motor neurons. And then those cells are injected directly into the spinal cord. The spinal cord is a really small structure that has a lot of important functions. So the first goal was to make sure that that was a safe thing to do. Patients who receive the injections then require long-term immunosuppression. At this point, a phase 1 trial is complete. Phase 2 trial results were just announced in March, and the results are very promising. This is a picture of a spinal cord with the arrow pointing to a site where stem cells have engrafted into the spinal cord. This is a picture of, so I've said that you're injecting stem cells into this structure that's about the thickness of your thumb that has a lot of important structures in it. And so they had to develop the technology to do this, and this is the neural stem stabilization and injection device. So the protocol was that they used NSI 566 spinal cord-derived neural stem cells. It was open label, dose escalating trial. They treated 15 ambulatory patients that were similar in terms of their ALS-FRS and other criteria. They found that the maximum tolerated dose was 16 million transplanted cells in 40 separate injections into the spinal cord. And based on positive results, a later stage trial is planned for this year. All of the results were determined 9 months post-surgery, and as I've said, they were 15 similar patients. And what they found remarkably was that 47% of the patients responded. And what they mean by responded is that during the course of their trial, the 9 months, these patients basically didn't have a decline or had an improvement in their ALS-FRS in that 9-month period. So those patients were stable. For the responders, by the end of the study, their ALS-FRS was 37, and I said normal is 48, which represented 93% of their baseline score. For the non-responders, their ALS-FRS was 14, which represented 35% of their baseline score. So quite a remarkable difference in terms of responders versus non-responders. The forced vital capacity, which is a measurement of breathing, for the responders was 94% of their starting FVC, and for non-responders it was 71%. One of the other remarkable things about the study is that the researchers felt that based on the patient characteristics and responses that they could have some ways of predicting who would be responders in the future, so they could tailor their clinical trials better in the future. So now I just want to shift gears and talk about antisense therapy. Antisense therapy is a very exciting therapy for, basically it's going to be for familial types of ALS, so particularly SOD1 and C9orf72. And this is based on the idea that what happens in some forms of ALS is that proteins misfold and aggregate and build up in the neurons and cause toxicity. And so the theory is that if you can prevent the buildup of the proteins, or if you can prevent those proteins from being made, that you can prolong motor neuron survival. And so antisense therapy is aimed at reducing the amount of abnormal protein. And so just going back to basic biology, so you know that in order to make a protein, you start with DNA, that gets transcribed into RNA, which then gets translated into the protein. And so what antisense technology does is the researchers synthesize, they make a chain of oligonucleotides that can bind with the messenger RNA to prevent it from becoming protein. So it reduces the amount of protein. And so it's been found that in the mouse model, the SOD1 model, the antisense therapy reduced the amount of abnormal SOD1 protein and slows progression. There was a recent phase 1 trial called ISIS SOD1 RX in humans that is a trial that confirmed safety, but it was really too small to look at efficacy. And so a phase 2 trial is in the planning, and I'm told that's quite close to coming to starting enrolling. There's also clinical trials for C9 or 72 in the planning stages. And so clinical trials like that will make it more important to do genetic testing of patients, since a certain number of sporadic patients are actually familial. So I want to talk about another clinical trial that's coming up that we're going to be involved with. It's a trial using L-serine. L-serine is an amino acid that is in our normal diet. But it's based on the idea that, that cyanobacteria may be an environmental risk factor for ALS. And, and we're trying to identify all the risk factors for ALS, and this may be one of them. So cyanobacteria are also known as blue-green algae. They're ubiquitous in the environment, in the water, the soil, and the food train, and they produce a toxin called BMAA, BN-methylamino-L-alanine. And these are just pictures of the cyanobacteria or the blue-green algae. They tend to build up in stagnant water, and we see them all over the place. And so there's some data as to how BMAA may be toxic. And so one of the things BMAA does is it mimics L-serine, and so it gets incorporated into proteins, particularly neuroproteins, and causes them to misfold. And it's thought that that's one of the ways that BMAA may cause toxicity. It also causes glutamate toxicity and oxidative stress. So the human exposure to BMAA is widespread, and it's felt that it has the potential to be an environmental cause of ALS. And this is suggested by the fact that clusters of ALS have been associated with dietary or environmental exposure to BMAA. And there have been several studies that have shown that BMAA levels are higher in the brain and spinal cord of patients with ALS. It's also been shown that this is higher in patients with Alzheimer's as well. So the idea with the L-serine clinical trial is that theoretically high levels of L-serine can replace BMAA and prevent motor neuron death. When L-serine has been added to neuronal cultures, it's been shown that it can prevent the insertion of BMAA. It's a funny thing to say, BMAA. So there's a clinical trial with L-serine starting soon, and I would just say that even though this is something that's available, the clinical trial is very important in terms of looking at safety and efficacy. And this is one of the trials that we'll be involved with. I mentioned earlier that neuroinflammation may be important in ALS as both the cause and something that helps the disease progress. And it's been shown that about 50% of sporadic ALS patients have markers of inflammation. And these aren't markers that we can test in the lab, commercially in the lab, they're research markers. But in ALS, inflammation can trigger macrophages to destroy healthy as well as damaged motor neurons. And this is a cartoon of macrophages, which are in green, gobbling up a motor neuron. And macrophages are really sort of the garbage collectors of the immune system. And there have been studies that have looked at macrophage activation in ALS, and there has been some correlation with the degree of macrophage activation seems to correlate with the rate of progression of ALS. The more activated they are, the faster the progression. So sodium chloride is also called MP001, and we're going to be starting a clinical trial with this sometime soon. And this is MP001 is something that modulates the activation of macrophages, thereby decreasing neuroinflammation. We were involved in a phase 2 clinical trial where patients received IV NP001 for 3 months during a 6-month trial period. And this trial showed positive results, which have led to the planning for a phase 3 trial. And the results were impressive. This graph just shows the number of patients who were responders. And just like the prior clinical trials, responding means that during the time of the clinical trial, there was no progression, no deterioration, or there was improvement. And so for this clinical trial, in the patients who received placebo, 9% of them had no significant deterioration during the clinical trial. But 27% of the patients receiving the MP001 were stable, did not progress during the trial phase. So this is I think it's quite a striking finding and very encouraging, and has led to the development of a stage 3 clinical trial. So in summary, so this medication led to a halting of progression in a dose-dependent fashion in 27% of patients who were the responders versus 9% of controls. The other important aspect of the study is that when they looked back at their research, they found that all of the responders were patients that had markers of inflammation. So that's leading to the possibility of new clinical trial designs where you look and see who has inflammation, and those patients will be the ones exposed to the medication. Tirasemtiv is another medication that we're about to start a clinical trial for. We were involved in the phase 2 trial, phase 2B trial, and we're starting a phase 3 trial soon. And I'm just going to read this and then tell you what it means. Tirasemtiv is a fast skeletal muscle troponin activator that sensitizes the sarcomere to calcium. And what that means is that for every motor neuron electrical impulse, you get a more vigorous, a stronger muscle contraction. And so in the phase 2B clinical trial, what they found is they had a positive result in that the vital capacity and the muscle strength declined significantly more slowly in those receiving tirasemtiv. And so this is just a slide that shows that. The red line is the rate of decline of those on placebo, and it's significantly more rapid and steeper than those receiving the tirasemtiv. So it's a totally different approach to treatment of ALS, but it's very promising. Retigabine is a clinical trial that's about to start as well, and it's very interesting, and it sort of makes sense scientifically. So using very neat stem cell technology, researchers are able to take skin cells from patients with ALS and turn them into motor neurons, and then grow those motor neurons in petri dishes. They don't have all the characteristics of motor neurons, but they have many of them. And then they can study the motor neurons directly that way. And using this technology, they found that motor neurons in culture from ALS patients are hyper-excitable. And they found that this is because of a deficiency in potassium channels, channels that let potassium into the cell. Now, retigabine is a seizure medication that is already available. It's very hard to get, but it's available. And it's a seizure medication that's a potassium channel activator. So it makes the potassium channels work better. And so this medication reduces hyperexcitability. And so they've looked at retigabine in motor neuron cultures, and found that it does reduce hyperexcitability and it prolongs survival of the motor neurons in culture. So it's sort of an exciting approach to treatment of ALS, and this is something that's coming up soon as well. I've talked probably for a couple of years now about the diaphragmatic pacemaker, and it's been around for a couple of years. And basically what the pacemaker is, it's a surgical procedure to put electrodes directly into the diaphragm. And then you see that wires come to the surface of the skin, and several times a day you hook those wires to a stimulator, which is in the patient's pocket, and you exercise the diaphragm. The diaphragm is the big breathing muscle for the body. And this was first developed for people with spinal cord injury to try to help breathing. But in ALS, the idea is to use it to improve diaphragm strength and stamina, to build the muscle up so that as the disease progresses, there's more reserve in the muscle, so it'll deteriorate more slowly. So there was one trial that there were results for. It was about 98 patients. There were no controls, which is an important aspect of the research. And what they found is that in the patients who received the DPS, their survival was 16 months longer than similar patients who did not receive it. They also showed that the thickness of the diaphragm increased, and there was improvement in respiratory function as measured by the forced vital capacity. We are now involved in 2 clinical trials to get more data about this, the pacemaker. One is just sort of a data collecting. The other is a placebo-controlled trial where for every 3 patients, 2 patients get the actual procedure. And I would say despite the encouraging results, early results, this placebo-controlled trial is very important in terms of proving efficacy. Now, we have a lot of data from the trial that we're doing now, and that data has been submitted for publication. I'm not privy to it because it's not been accepted yet, but what I'm told is that it's very promising and encouraging as to the effects of the pacemaker. You can't have any talk on ALS without talking about nutrition and calories, and I think you all know that I beat that pretty hard, that try not to lose weight. And there's a lot of data that people with ALS are hypermetabolic. They're burning more calories. And so there is a tendency to lose weight, which seems to correlate, whether it causes it or not, it correlates with more rapid progression and poorer prognosis. And I mentioned already earlier as well that people with a higher BMI seem to do better and have a lower risk of getting ALS. So knowing this, there's a clinical trial with just a small number of patients where patients with feeding tubes received one of 3 feeding tube formulas. One was just standard of care. The other was high fat, high calorie. The other was high carbohydrate, high calorie. And what they found in this small trial was that survival was significantly prolonged for the high calorie diets. And interestingly enough, it was most prolonged for the high carbohydrate, high calorie diet. And so based on this study, there are a lot more trials that are starting to look more at nutrition in ALS and what the appropriate type of diet is. And I still come down to the fundamental rule that to prevent weight loss, whatever it takes, just getting enough calories. I just wanted to mention coconut oil because it's in all the chat rooms. And there is a theoretical basis for the effectiveness of coconut oil in ALS. And that's based on the fact that coconut oil has a lot of medium-chain triglycerides. And medium-chain triglycerides get converted into ketone bodies, which can help improve mitochondrial dysfunction in ALS. So I've mentioned that in that busy slide, I showed that mitochondrial dysfunction was one of the things that's been reported in ALS patients. And so this may be a way of helping to correct that. The other way in which coconut oil may slow progression is by acting as a high-calorie supplement. They've looked at different diets in animal models of ALS, and they found that ketogenic diets, which is high fat, normal protein, low carbohydrate, and high fat diets were associated with a slower motor neuron loss in ALS animals. And so the range of what people take is anywhere from a tablespoon to 4 tablespoons, and it can cause diarrhea. Vitamin D, I just want to mention because there's just increasing evidence about how important vitamin D is, and we always think about vitamin D as being important for bone function, but it's really a potent hormone with diverse biological functions. And I've just listed all of them, or some of them, but it protects against neuronal damage, it attenuates oxidative stress, it promotes breakdown of misfolded abnormal protein, it modulates inflammation, increases growth factor, et cetera, et cetera. So it's a very important hormone. And there have been a number of small series and small reports that seem to support the importance of vitamin D in ALS. And so one of the things is that vitamin D levels are generally low in patients with ALS, particularly in Oregon. I have not yet found anyone with a normal vitamin D level that I've tested, except my husband, who drinks 2 gallons of milk a day. One study showed that people with ALS who had severe vitamin D deficiency had a 4-fold rate of decline and shorter life expectancy than those with a normal vitamin D level. And then in patients, another small study, in patients who were taking vitamin D, there was a slower rate of decline of the ALS functional rating scale. And then they've looked at the role of vitamin D in cultured motor neurons, and it seems to help with motor neuron survival. So I check vitamin D in all my patients. So exercise is something that comes up a lot. Patients are always asking whether they can safely exercise, how much exercise is the right amount. And with exercise in ALS, one of the concerns, the theoretical concerns, is that excessive exercise puts more stress on the motor neurons and can cause them to deteriorate more rapidly. There's actually no data that I could find that proves that exercise is harmful to patients with ALS. And I think the community's consensus is that moderate aerobic exercise, such as stationary bicycling or exercising on a treadmill, have the potential to help neurons and muscles. And I've just listed all the things that this type of exercise does. It increases growth factors, boosts energy supplies, removes damaged proteins, et cetera. So there was one clinical trial several years now ago that started to look at this. And they took 40 patients with ALS, and they exercised them moderately, which was on a treadmill to 70 to 75% of their maximal heart rate. And what they found was that there was a decrease in the rate of decline of the ALS functional rating scale and improved survival. So there are currently a number of clinical trials that are trying to look in more detail at different exercise programs and its effect on motor neurons and survival. But I still believe that moderate exercise is good, whatever you can do safely without exhausting yourself or causing discomfort. So in summary, I think there are many new genes which are causing or increasing the risk of ALS that have been discovered recently, and that's increasing our understanding of ALS. And one of my slides, I didn't go in detail, but just in the last year, in 2015, there have been 3 new genes identified as a cause of ALS. So it's really increasing. And then the increased understanding of the pathogenesis of ALS leads to new targets for treatment, and that there really are multiple new and exciting clinical trials that are either in the process or in planning. And I only went through a small number, that, particularly ones that we're going to be involved with, but that are really imminent. So that's it. What? You feel hopeful? I feel very hopeful. Yes. Every time I go to 2 or 3 ALS conferences a year, and I always come away saying, "Wow, the treatment is just around the corner," because there's so many breakthroughs being made, on a weekly, monthly basis. So it really is an exciting time in the field. Very hopeful.